Right, we'll start in about 1 minute, please. Super. Right, good afternoon and welcome to the Adults and Health Committee's Health Scrutiny session this afternoon. Reminder for our co-opted members who've joined us, and you're very welcome, Councillor Garvey, Councillor Horgan, Councillor Noads. You're all welcome. Nice to see you here. And welcome back to the County Council members who are in the room. Just a reminder, once again, that we do allow filming and photography. So feel free to take pictures and use social media as long as it doesn't disrupt the proceedings. But please, everyone, turn your mobile phone to silent or vibrate. This meeting is being live streamed, and a recording of the meeting will be available on the County Council's website. There isn't a fire alarm test scheduled for today, so if the alarm sounds, I will adjourn the meeting immediately. We'll leave via the side doors at my left and use the fire escape next to the kitchen to make our way to the assembly point, which is in the car park. Once again, I welcome the co-opted members. Two substantive items this afternoon for health scrutiny. The first one on health inequalities and the second one on CPFT. So I look forward to both of those. Is Jess Slater? Right, Jess, I shook your hand, but I wasn't sure it was you. Jess Slater is the new Chief Executive Officer at Health Watch, and it's the first time I think you've been at the committee. And so we see Health Watch as a very important partner for us in this committee, and you're very welcome. Perhaps you'd like to say a few words just to introduce yourself.
Hello, yes, my name is Jess Slater. I'm pleased to be with you. I've been in post since the 10th of May and hit the ground running. I will have a few comments to make this afternoon, so I look forward to contributing to this meeting. And if anybody's got any questions for me later, of course, please do ask. Thank you.
And of course, we always welcome our ICB colleagues and the colleague from Cambridge University Hospitals. So, first item 8, is health inequalities. We've got two reports for this item, and they're on pages 131 to 158 of the agenda pack. We are pleased to welcome Louis Camphor, Deputy Chief Executive of the Cambridge and Peterborough Integrated Care Board, Jonathan Bartram, ICB Programme Director for Health Inequalities, Dr. Ashley Shaw, the Medical Director at Cambridge University Hospitals NHS Trust, alongside Jess Slater, who I've already introduced. And Health Watch have a standing invitation to our health scrutiny sections. Is Councillor Goodliffe with us or perhaps online? No, Councillor Goodliffe from the Children and Young People's Committee may be joining us, but I think isn't yet in the room. And before we introduce the reports, just a process question. Councillor Taylor.
Chair, would you mind if our guests would just all introduce themselves? That would be really, really helpful. Thank you.
Okay, when you do your presentation, can you say your name and your job each time? Not each time, on the first time. So to respond to what Councillor Taylor has said there. Now, we've read both reports and met informally to discuss them already as members. So let's start with a brief introduction and then we can move into questioning. And I think Louis is going to start first.
Thank you, Chair. I'm Louis Camphor, Deputy Chief Executive of the ICB. I'm going to hand over to my colleague, John Bartram, actually, who's our Programme Director leading in this area, just to quickly take us through the report. Thank you, John.
Just say for all the speakers, the audio isn't brilliant in this room. And what you do is you move the whole unit near to your mouth, right? Don't try and lean forward, actually move the whole unit so that you're speaking as close as possible to the microphone. Thank you.
Hi, thank you, Chair. Good afternoon. John Bartram from the Integrated Care Board. I'm Programme Director within our strategic commissioning unit and have the healthcare inequalities programme under my remit. So I'm going to just quickly take you through the report. The report very much focuses on the alignment for the ICB to the NHS England's strategic priorities for tackling health inequalities, which focuses on those 5 strategic areas outlined in the report. And the core 20 plus approach that's formed central part of how we're taking or tackling inequalities within Cambridgeshire and Peterborough. The report obviously highlights a huge amount of the inequalities that we see across Cambridgeshire and Peterborough, both in terms of the differences in life expectancy and also healthy life expectancy. One of the things that the aims of the report to draw out is the fact that actually tackling health inequalities requires a collaborative approach, not just from healthcare, but of course some of those wider determinants that we know that cause some of the health inequalities that we see, both in terms of life expectancy and healthy life expectancy. Within the report, there are examples of some of the initiatives, some of the programs of work that we've embedded that across the system and across some of the NHS providers that tackle healthcare inequalities. They're aligned to that 5 strategic priorities and the core 20 plus approach, and the appendix that accompanies the report tries to summarise that and how that strategic alignment has taken place. The other element of the report also looks at some of the improvements that have been made, particularly around some of our coding and ethnicity coding in particular, to increase and improve the analysis that's required, those data-driven insights into identifying healthcare inequalities in the first instance, as well as introducing some of the more radical changes of programme implementation, such as the Your Healthier Future approach, and moving care into a more preventative out-of-hospital approach to upstream. So it's a very brief overview, Chair. I don't know whether that's sufficient or whether you'd like me to go into any more details at this stage.
I think it's good. I think we've learned in these sessions, it's the questions and discussion that provides the learning, and we are grateful for the papers that have been brought forward. I don't know if our colleague from Cambridge University Hospitals wants to say anything introduction though, so he's introduced himself at the very least.
Hi, good afternoon, Chair and committee. My name's Dr. Ashley Shaw. I'm the medical director at Cambridge University Hospitals, or Addenbrooke's and the Rosie as often more familiarly known. So obviously CUH is a large teaching hospital, and we provide care to patients for local care, regional care, and in some instances national care. And we have primary responsibility for secondary care, so people who are actually ill, who've been referred in, more so than preventative. We've been doing a number of things to try and improve on health inequalities for our patients, and probably these can be broken up into a few key areas. First of all, to improve access to care. So in that respect, we're doing things like improving the data that we collect so that we understand our population more, improving the accessibility of things like the website, which has recently been revamped, trying to think about how our models of care change to enable people who can't afford to travel into the hospital on quite a frequent basis can be managed safely. The language that's available on our website and on the data that goes out to people. And how we understand different communities that don't access healthcare well. We've been thinking about models of delivery. And so the things that we deliver are some of our screening programs. We've been thinking about how we get to those patients who don't routinely access screening programs as often as we would like. Secondary prevention with things like smoking cessation. The emergency department, where we know that those with disorganized lifestyles, such as the homeless communities, access ED in a different way. We're working with those to try and reduce those issues. and outpatients, where we're trying to change the models of care so that, as I say, people don't need to drive all the way into Cambridge to get the consultation that they need, and we're trying to reduce the number of follow-up work. And then finally, the big area that we have is research and education. So that's really a combination of educating our staff to be able to consider all these different things when they're planning their services. And secondly, medical research. So how do we design our research to be more inclusive of a wider population, both inside and outside of Cambridge? And more broadly, we provide the fundamental building blocks for research across the country with things such as the bioresource, where we provide a database of patients that people can voluntarily sign up to, and then researchers from across the country can apply to access that database, so they can, in one fell swoop, access a whole country's worth of patients. Thank you. Happy to take any questions.
Okay, thank you to all of you, and each of you. We've divided the questions into 3 rounds. The first on identifying and addressing inequalities, which is going to be fairly broad and pick up on everything in your reports. The second one on partnership working, and the third one on funding. Okay. For the first round, I'm going to ask Councillor Horgan to start, please.
Thank you, Chair. Yeah, I'm intrigued. I obviously understand that it is a delicate balancing act, priorities versus resources. That's you know, irrespective of whatever industry it is, that's always a challenge. But in terms of listing priorities, I'm just trying to understand it. Something that intrigued me. And my question is, how are measures to tackle health inequalities weighted against clinical need in the allocation of resources, given the many pressing demands on the limited NHS resources? Thank you, Chair.
I do them round, so make a note of the questions. It will tend to be 2, 3 or 4 to answer it in one go. Councillor Dr. Nawaz, I'll leave to your discretion how you organise your different questions here.
Thank you. Would you like me to start now, or? Okay. Sorry.
Sorry, Chair, but I really think it helps to do them one at a time. Then we don't repeat ourselves when we ask the question, and it's this bit kinder on the questionees.
I do know that, but we've discussed this in spokes, and we came up with a good compromise, and that's taking them in small rounds with the opportunity for members to come back. So I'm going to stick to what was agreed in spokes. Councillor Dr. Nawaz.
Thank you. Yeah, I didn't think I would find report reading so interesting, even fascinating, but that is the case, sprinkled with healthy degree of disappointment, I have to say. There are a number of initiatives and a number of groups that have been constituted to tackle these inequalities. I did wonder whether there was kind of overloading of the clinical aspects with bureaucracy, but that I'm sure you have good reasons for doing what you have done. Given that Fenland has the most dramatic disadvantages in terms of health, all the health indicators, all the
So I'm really sorry to interrupt. This is not just you, but to all the speakers. What happens is we turn and we start talking to the guests over here, but we go too far away from the microphone. Again, what's just is move your microphone like this so that you're speaking directly into it, because people are not able to. So move it right over to your right-hand side if you want to look at the speakers then.
Okay, well, can you hear me now?
Only if you carry on talking into it.
Yeah, okay, I will carry on talking into it.
Much better.
Right, okay, thank you. Thank you for that. I was saying there are a number of initiatives and a number of groups that have been constituted to tackle some of these inequalities. And I do wonder at times whether it is overburdened, the system is overburdened by bureaucracy. But that I'm sure you have justifications and reasons for those. Coming back to Finland, looking at all the KPIs, all the metrics, Finland is at a dramatic disadvantage in terms of health inequalities. What if I read on the background information figure 1 or the image 1 together with 1.20, that I think just about sums up the crux of the issue that we have. And 2.5 indicates the complexity that may not necessarily have been needed, yet is incorporated into the tackling of this issue. So my suggestion is that, given what I have just said about Finland in particular, and given that what is said in 1.20 and image 1, wouldn't it be more appropriate for further geographication, if you like, rather than I know you've got the core plus 20 plus 5 and all these initiatives, but how about geographication, if I may devise that word, of all those initiatives, so that these resources are focused in the most needy area, in this case, Finland. Now, it is, I think, well known, and I had the good fortune of going around some villages last week. The issue there, main issue seems to be accessing their doctors. So maybe incorporating all those into setting up an additional surgery in, say, Whittlesea. Whittlesea is something that I'm very familiar with, so that the outlying villages could easily access. And one of the issues that was highlighted, Chair, during my doorstep conversations was transport. For example, one person missed his follow-up appointment for leukemia because there was no bus, no train. He didn't drive. He couldn't afford the taxi, which is probably around £40 per trip. So all of those things incorporated. Can the sources be focused on the most needy area, which is Finland, and to bring these services even closer to the residents? Can I suggest that part of that approach be additional GP surgery in Whittlesea, in Wisbech, in March, in Chatteris? Thank you very much, Chair.
And can I just give you a chance to ask a second question, because I'm trying to get as many members in this afternoon, and you suggested 2 or 3. Would you like to ask your second question of the remaining ones there, please?
Yes, thank you. The second question refers to what I had expected. One of the metrics of measuring the equality or inequality of health services is the neonatal, perinatal, maternal mortality, as well as the infant mortality rates. Now, those are missing. They were missing. Neonatal mortality rates have been supplied with a proviso that the maternal and perinatal were apparently significant, if I understand the lining correctly. Now, I challenge that. The neonatal mortality rate has been given as 2.1 for Cambridgeshire, compared to Luton, which was 4.9, and England as a whole at 2.9, I believe. Now, I challenge that because I think, by very definition, the perinatal mortality is going to be higher than the neonatal mortality. And for those lay people who may not understand, the perinatal includes stillbirths, whereas neonatal is live births per 1,000. So I would ask that those be included into these metrics when determining the inequalities, health inequalities, and provision be made, and with a further geographication of these metrics, the 2.1 or 41 deaths for the whole of Cambridgeshire is given, but I wonder how this splits up into the 6 constituent districts. It may be much higher in one district and much lower in the other to bring an average of 2.1, which may not seem to be too concerning. Well, the one with district with a higher rate would be the one that I would be concerned with. So that is my second question, Chair.
Thank you. First round of answers, please.
Excuse me, Chair. Could I just check where that data's come from that you've just quoted?
That data was given to us, Chair. It's in the appendix, I think, somewhere in the report that we got. It was an additional piece which I'd asked for the pre-meet.
I think maybe from the public health team of the county council. So we looked at some of the stats as well from them. So I think that's where that may have come from. I'm having that whispered into my ear. Okay.
Just to
yes,
say, we
indeed,
don't have that
I beg your
data.
pardon. Indeed, Chair, you are absolutely right. It came from public health.
Just to say, we don't have that data to comment on it. So but I could talk a little bit in a second. But if we start with the others.
And I'll ask Sally to come back maybe to comment and afterwards for completeness.
So I'll start and then I'll bring colleagues in as appropriate. So I think in terms of the sort of balance between addressing health inequalities and sort of meeting clinical need in an environment of constrained resources, I think the report outlines sort of a number of areas that we are trying to focus on. But you're absolutely right. That is something that we constantly need to take into account. I think, though, we also need to acknowledge that health inequalities drives costs. And, we see in our data that our patients from more deprived areas are more likely, for example, to end up in an emergency admission, end up in A&E, and end up in a crisis, which actually costs a lot more money than it would have been to try and prevent that crisis in the first place. So I think by sort of addressing the outcomes and the service provision in such a way that we are eating into health inequalities, there is also a financial benefit to us, because by achieving a better outcome for the patient, we are actually becoming more sustainable as an NHS as well. So I think there's sort of that side to things. We are trying to, we've incorporated a sort of a health economics approach to all our investments, where we are absolutely trying to take into account health inequalities, all the impact on health inequalities on all the investments that we are making. And we need to be really careful. But I think, the drivers of health inequalities are also, in many cases, the drivers of very significant costs. If we can avoid an emergency admission, we save money. And the report outlines programs where we are absolutely trying to do that, actually working very closely with public health colleagues in areas for clinical risk factors for cardiovascular disease, for example, which will benefit all of us in the future if we can get that right, if that makes sense. So hopefully that sort of answer is a difficult balance, always difficult balance to strike, but I absolutely believe, improved outcomes leads to more sustainability. On the second point around the sort of geography. So again, absolutely, we need to look at how we're balancing off our resources against the areas of most need. And in some cases, that may be additional capacity, as you've requested, additional GP surgeries, care closer to home. But in many cases, what we're also seeing is that the inequality is driven, in the example that you've used, by the way that we're expecting our patients to engage with us. what we're very much trying to explore at the moment is how we can create a different sort of offer in the NHS, a left shift model that takes into account far more about the patient's individual needs when we offer services to them, and not just send them a message to say you need to be in this place at 4 o'clock on a Tuesday, for example. The sort of cardiovascular disease program that I referred to earlier is an example of that, where we are using technology and data in a different way to make it really easy for patients to engage with us, and in some cases sending equipment to their house, for example, if they can't go to an appointment to get something done, which I think is a real game changer actually for the way that we provide services. That won't work in all cases, but there's a lot more that we can do to understand the specific risk of the individual and their ability to be able to comply with an appointment. In the individual's case that you just mentioned, you know, that's not an acceptable place to be. There are also other avenues available to patients, you know, patient transport services and mechanisms by which we can help patients to go to appointments, you know, if transport, for example, is not available. But I think the whole model that we are looking at the moment, and we've, you know, discussed at Integrated Care Partnership, is one that shifts left, gets more proactive, and makes it easier for patients to access care. So hopefully that starts to answer. John, was there anything that you want to add to that?
No, I won't at this stage. I'm sure it'll come up in a bit of other questions.
Thank you. Yeah, yes, the health inequalities, I think, if you remember, starts off at birth with poverty, which is obviously not necessarily within our remit, education, job opportunities, etc. So many of the things are in place that we are then fighting, swimming upstream, if you like, by the time they come into the realm of healthcare. In terms of the things that you mentioned that are within our gifts, the things that we see is that, as you say, the patients from the Fenland communities, when they're trying to access Addenbrooke's and CUH, the challenges that they have are travel and the paucity of travel options within there. And the second big thing that we see is patients who work on 0 hours contracts, who physically can't afford to take the day off work to come to that outpatient appointment for whatever reason. Well, for the reason that they just can't afford it. And then they look at the time and how can they get there on a certain day, you know, if our clinics. Now, some of those clinics, as you alluded to, you gave the example of a chemotherapy or a leukemia clinic. That wouldn't be possible to deliver actually in those places because there wouldn't be enough demand. But what we're trying to do is to change the model of care where we can shift the follow-up appointments to virtual clinics, where we will either have a video call or a telephone call to save you coming all the way to the hospital just to be told everything's okay. And we've introduced the community diagnostic centres, and there's one in Wisbech and one in Ely, as you know, so that patients can get blood tests, imaging tests, cardiac scans, and a number of other things in those centres so that they have a less distance to travel. And running those is a balance of, there's a question of scale to make them economically viable, but actually reaching out into the various communities. So we are trying to change the models of healthcare to try and reduce the burden on patients having to get all the way into Cambridge.
Okay, still under this heading, I've got Councillor Seif and Councillor van der Van.
Thank you, Chair. I'll face the panel, as it were, and then you'll be able to hear me. We have the statistics on life expectancy, and they are obviously significant. We all know them. We know them to be objective. When somebody dies, they're registered. It has been falling, as I understand, slightly. But I'm less concerned about that than healthy life expectancy. And I just wonder whether you can, this is a question about clarification of exactly what it means, because you tell us that it actually has, the figures have remained pretty stable over the last 10 years. I think that's in paragraph 1.4 of the report anyway, which is a bit disturbing because many of the things that you and other health bodies have been doing across the country is some of the things that you are talking about here. For as long as I can remember, people have been urged to give up smoking and to watch their weight and do more exercise, etc., etc. Notwithstanding what, I'm sorry, I haven't got your name, but what you just said about making it more accessible. Do you, so one last question on nomenclature. There is obviously, and I accept that there's a difference between those who live in deprived areas and those who live in the more wealthy and are able to probably look after themselves much better. So healthy life expectancy would be normally different between those two broad groups, although you have said that the overall figure hasn't changed. Are there some of the things that you're now proposing under this program really going to change it, or is it going to make no difference because we've been doing it all these years and it's remained exactly the same as it was for 10 years? Or
Okay,
do you
thanks.
have different statistics as between healthy life expectancy between those who live in deprived areas and those who don't?
Thank you. This
And
isn't
I understand, sorry, that
Hold on,
figure
Jeff.
anyway
Hold on.
is
Hold on, please.
subjective because it's
Councillor
self-assessment,
C,
isn't it?
can't ask you to hold on.
Sorry. Yep.
It's not a criticism of you or anyone, but we're not going to get many questions in unless we're all more concise, okay? So try and stick to your question and not give too much commentary on it, but that's not just directed at you, Councillor Steve, it's directed at all of us, including me. Councillor van der Ven.
Thank you. Like Councillor Noaz, I represent an area much of which has basically no public transport and no active travel links to the health services. And you've answered some of the question I was going to ask. Thank you. But I wondered if you see specific area for collaborative work with the local transport authority and local government to create new options? Or do you feel that that space is one that you are able to engage in? It needs to be a conversation because you don't have the requirement to fund transport for everybody, do you? Thanks.
Thank you. Councillor Hay is indicating this round, so I'd like to take her next, please.
Thank you, Chair. Reading the paperwork, I was very pleased to see that you're looking to increase the number of cancers identified at stages 1 and 2. Namely, you've got 2 key programmes for lung cancer and cervical cancer. What I would like to know is what, if anything, is being done to highlight the need for men to get tested for prostate cancer and to get the message out to the general public what signs they should be looking for this disease.
And one from me. When I read these reports, there's a lot of very good activity there that you can't do anything else than welcome. But what seemed to be missing to me was the idea where we're actually going to make a difference, and it can and is making a difference. And I don't think you can measure that just on the lifetime of the ICB, because that's so short, really. But I think we do know Cambridgeshire and can talk about where are the worst inequality problems in our population and what is and can really make a difference. And I didn't feel that reading that from the paper. I'd be interested in your response. I also felt there was almost a shopping list of things that everyone might do, and if you don't do them, you're going to get criticised, rather than making real choices. That may be unfair. It may be about the report, not actually what you do. But I'm particularly keen to think, where have you studied an idea from elsewhere and pinched it, and then we're doing it here because it really is working? I didn't really get a feel for that. It was all just inward looking. And where are we innovative? Where are we doing something that others aren't, that we can bang the drum about? I didn't feel that I saw that in the report either. So interested in all of those points. Back to the speakers.
Thank you. Hopefully I've jotted all of that down. I think the questions are actually quite linked, I think, potentially. So if you just bear with me a little bit, I'll try and explain, I think, what will be different, actually, in terms of the approach that we are taking now. So the bit that I think is really, really different now is the fact that we have really incredible data on our patients. And I think for the first time, we are able to look across our population and understand what mitigatable or modifiable risk factors we have in our population. I'm an accountant by background. I used to be a finance director. I'm new into this role, relatively new into this role, 2 years in. I never ever realized the extent to which we've got invisible, modifiable risks sitting in the population. You know, if we take the Finland population, if we take our whole population, actually, if we think about under 75 mortality and the drivers between the difference between the most wealthy and the most deprived, cardiovascular disease is one of the big things. We can now see in our population who has clinical risk factors that's likely to lead to cardiovascular disease later in life, and go after those patient cohorts in a way that we were never able to before, because we can pinpoint the individual and we can work with them to optimize the risk factor. And we can do that in two ways. We can do it at scale. So we're contacting patients on behalf of their practice, and we have a series of phone calls with them. We explain the risk factors, we explain the lifestyle choices and the changes that they can make, and we can offer treatment, something like a statin, for example. But we can also do that by a very individualized approach that focuses on the individual. Now, coming back to the point around resources, my opinion is we need to do both of those things, because a cohort of our population, and we're seeing this in the proof of concepts that we're doing at the moment, are absolutely responding to that approach. And we've got 2,000 patients now in the short space that program has been running that has opted in to, for a statin, for example, to reduce that clinical risk factor quite significantly. But we also know, and the beauty of using the data in this way, we also know exactly who hasn't, taken any mitigating action, and who we still need to work with to try and optimize that. And that's where our sort of integrated neighborhood team infrastructure really kicks in, because we need a very individualized approach. The other beauty of this is we can do it in 200 languages. We can optimize it in such a way that we take into account the individual's age, all their individual risk factors, and we can tailor the advice specifically for that. All of those things are capabilities that we didn't have before. So I'm really excited about the fact that actually the next 10 years will be really different, because we now have these capabilities and we're absolutely using it. And it's not just in health, because we've had conversations with officers in the local authorities, because the more that we combine our intelligence, the more we're able to understand about the sort of overall risk drivers of an individual or a family, which leads to some of the crisis that comes later on. And our high intensity user program, for example, that's in the paper, is a good example of that, because the more we understand it, the more we can mitigate. The other thing that I think has really changed is our capabilities to do things in ways that we've never been able to before. I was on a call on Friday with an innovator who can do a 3D heart scan with a piece of equipment that looks like my phone, in someone's house, in a GP surgery, out in the community. Doesn't need a GP or a doctor to do that. Almost anyone can do it, because the instructions are really simple, but it gives us information that almost diagnose that condition instantly, and really is very clear about what the onward steps for management of that condition would be. I can name about 50 other examples of that, things that are coming down the line that we need to maximize on as a health and care system. So to answer your question, I think we're in a completely different environment, and what we are not doing is a blanket approach to say stop smoking. We're able to say to the individual, these are your risk factors, and that ability, I think, will just increase. And I think what is important as part of this is that we often think about the use of data as negative, because all we hear about is, when data is leaked, and people are worried about that. And I can absolutely understand that. I am worried about that. But I think we don't talk about the positive things that we can also do for our population by using information in different ways within certain guardrails, obviously. But I think it's a really different environment. And to link to the transport point, obviously, we want to support our patients. I think we would find it really difficult as an NHS necessarily to invest. We've got lots of rules that we need to play by. But some of the examples that I've used earlier hopefully indicates that actually it's not just about, as Ashley said, asking a patient to come to Addenbrooke's, asking a patient to come to Peterborough City Hospital, because we recognize that's really difficult for some of our patients. But it's how we can make it easier for them to get done what they need to get done to optimize them. And just linked to the cancer screening, again, I can probably list about 50 things that's changed really in that environment, where we can make the screening process so much easier for patients and do it in a much more consistent way by the data. So we could do a public health campaign and we can say, all men over a certain age should go for a prostate screening. But I would prefer an approach where we almost target the individuals that we now haven't in a much more systematic way and work with them to optimize that, because I think that's a much more successful approach than just doing the blanket sort of campaigns. Not to say we shouldn't do that, we should do both, but I think we've got almost a safety rail around the approach that I've just outlined that we could do in addition to, because, thinking about health inequalities, we recognize that for a lot of our patients, the cancers are identified much later on in an emergency department rather than through a screening process much earlier on. And so hopefully that sort of answers the questions in a slightly different way.
Anyone else in the line?
If I could just pick up on the cancer screening thing. So I'm a radiologist by background, so I kind of know a little bit about this, but there are two ways to look for prostate cancer screening. Just as an example of how difficult this is, there's a blood test which can be useful in a few instances, but will miss loads of cancers, so will give false reassurance. So that's not really recommended for a screen. That's not good for a screening thing. The only other way of doing it is to do an MRI scan of the prostate gland, which takes just over half an hour to do per person, and then needs a radiologist to report it. So there's no out there funding for it. So we don't have a very good, affordable screening program. And then even if you do find prostate cancer, quite a lot of the time, we're not sure what to do with it. So some patients we watch and wait. It's active monitoring. Some patients you take out the prostate, and some people you give radiotherapy. So we're not even sure which of those is the best option. So in order to get further forward on a screening program, you have to move through quite a lot of bits to do that. As you say, lung cancer screening has been very effective in moving towards. It's the first thing in 20 years that's moved the dial and done more stage 1 or 2 cancers. It's increased it quite significantly, and it hasn't yet been fully rolled out. So that's being rolled out around the country, and it's been rolled out in areas of greater deprivation first. So that's just coming really in parts of this region, but it should be coming very soon. There are other innovations such as the cytosponge, which was invented by a colleague at the Cambridge campus, which is literally you swallow a little ball on a string and you pull out the brush. It opens in your stomach, you pull it out, and it tells you whether there's an esophageal cancer. She's Rebecca, who led that work, I think first invented that about 20 years ago. And that's just the length of time it takes to get something from idea through to an established device in healthcare. So these are very frustratingly slow evolutions, unfortunately.
And can I come in just on the innovation point as well? So I think we need to look broader than just innovative sort of technology. And actually one of the key areas I'd like to highlight around where we're being innovative is around our high intensity use program. Cambridge and Peterborough are the only system within the country who've taken an approach to partner with the council, so Cambridgeshire County Council, on this piece of work to look at addressing high intensity use, which is often defined as 5 or more attendances at A&E departments within a 12-month period, rather than commission this to other providers. So we're very much adopting a partnership approach to look at supporting those individuals, because we are aware of the link with the health inequalities. Those people are often appearing at A&E, attending A&E frequently, not because they have clinical conditions, but because of wider determinants that are driving the fact that they are needing some sort of support that they're not getting elsewhere. So actually taking that partnership approach has now been praised by the NHS England and others afield. So I would like just to say that I think that is a very innovative approach that is highlighted in the report, but not technological in basis.
Thank you very much. And being nice about us obviously is quite nice, but it doesn't take away from the seriousness of your point. We've got 2 more rounds to go, so I'm going to go on to the partnership section of questions, and Councillor Daunton is going to be first, please.
Yes, thank you. Well, I won't repeat what's been said by others before me, and I'll try to be succinct. That you've got a paragraph in the report, I think it's 1.19, where you talk about Michael Marmot's work and the 10-year on, the review 10-year on. And there's a very interesting phrase in that where you say, that makes a strong argument that most of our health is determined by our social circumstances. And you've talked about partnership working, and obviously you're doing a lot of it. What do you think are the barriers to better partnership working, to improve partnership working, which would help you?
Thank you very much. Next, Councillor van der Ven, please.
How did I forget? With regard to the heavy burden on A&E ED, I think I've heard it said before that if only primary care could divert some of the flow to A&E, and there is certainly a cohort of people who are there because they couldn't get to primary care. Are you doing any specific work in the community in primary at GP practice level to support their ability to take on a greater cohort of patients? I haven't expressed that very well, but I'm sure you know what I mean.
And Councillor Tevlin, can you roll together both of your questions, please?
Sorry, is it possible to do mine afterwards? Because mine are sort of detailed. Okay, I've got 3 points. So my first one is I'm concerned about patients falling through gaps in treatment and ongoing care, especially vulnerable patients. What is being done to ensure that people who might be experiencing health inequalities are identified and supported, and who's taking responsibility for this? My second question to you is around how are you working towards treating patients holistically rather than in silo? Myself included, and various people I know with various health conditions end up being treated for an issue not that could have been prevented, and they're taken to one department when, so for example, in my case, a dermatology issue, and actually I need to see the gastric department, but I was refused any gastric treatment and refused any treatment. So I then had to pay privately for the right assessments to get to the bottom of it and seek holistic help to get to the bottom of my issue. So I know this happens time and again for patients missing out and unable to afford private sources, and my GP referred me to take private tests. That is not something very favourable to reducing inequality. So is there something the ICB can do in terms of a holistic approach for treatment and prevention rather than when it's too late and people are falling through the gaps? And my final point.
I think I'll just break there because there are 2 there. And can I just encourage members, I don't mean to be critical at all to you, Councillor Tevlin, but all of us could talk about personal examples, and we are encouraged not to. It doesn't take away from your question, which is, could there be a more holistic approach?
Yes.
But can I just encourage all members to not refer to their own individual experiences, because that's not our role in this scrutiny committee. I am going to ask for the answers now, if I can just hold you there.
Can I?
I'll come back to you at the end if there's time, but I'm going to fit in the other members. Let's take the answers to that round, please.
Thank you. So on the sort of partnership work, I absolutely agree that is fundamental for us to want to improve the outcomes for the population to become more sustainable. And I think that there is a significant amount of synergy between different organizations, because, you know, all the things that I talked about before that I won't repeat will drive pressures for both health and social care and wider. And so actually by working together, and some of the examples I've used and collaborating around understanding the population much better, understanding the risk drivers in the population much better, actually I think there is a significant amount that we could do together to help us kind of moving forward. I think the barriers from my perspective is quite often organizations are pressured, and you know, there's lots of priorities that we all have to deal with in our respective sites. And I think, you know, collaboration is so important going forward, and we need to prioritize it therefore. But it's so easy to get sucked into the priorities of the organization, the entity that you're working for. And I think our finances has to an extent been a limiting factor. But I think if you step away from all of that, there is a significant amount that we could do. And if we don't, it won't work. And so hopefully that helps to reassure. And I mean, other colleagues may well be able to identify sort of other barriers as well. On the primary care question, and GPs particularly, I think it is right that we've got significant capacity constraints and significant demand in general practice. And as a result of patients not being able to access what they need, they sometimes go to A&E. I don't think that's something we dispute at all. We've set out a couple of weeks ago in our strategic commissioning plan the kind of environment that we want to create in Cambridgeshire and Peterborough around healthcare, and particularly with the focus on working with our GP colleagues to help them with capacity, but also thinking about demand and how we could deal with patients differently when they're trying to access healthcare. At the moment, I think there is an expectation that, you know, accessing your GP surgery for everything and your whole healthcare pathway is the model that we've set up, and we are, I suppose, questioning whether there's other ways in which we can help patients through pharmacies, through different access points across the system that doesn't all need to go through general practice all the time, because that is a very valuable capacity for us and it's an incredible value add. And what we want to make sure is that we use that capacity for the patients that they really add value to. And there's a lot of work for us to do in that space. But again, it's such an important pillar of sustainability going forward. And you'll see if you read the plan that we've put to our integrated care board, that primary care sustainability is fundamental within that plan. And there's quite a lot that we're doing around that space.
Could you move the microphone and get a bit closer? Sorry, we
sorry.
could hear you, but
Yes.
it's a little bit soft.
It doesn't happen often that people can't hear me. John, did you want to pick up something on the vulnerable patients?
Yes. So, look, I'm not going to stay here and say that we get it right all the time. We acknowledge that people are at risk of falling through the gaps, and that is creating an inequality. I think, the whole purpose of the paper and presenting it today is to look at actually how do we get better at identifying those individuals and collectively, again, through that partnership working, identify opportunities to improve those pathways. So this is about hearing the experiences of people who we don't necessarily hear from, and I think the patient voice in the redesign of services and pathways is the enabler to actually addressing some of the gaps that we have in service provision. A lot of work is going into then making sure that we are using those patient voices. Healthwatch is a very valuable partner in enabling us to do that. I had the privilege of attending the annual conference just before Christmas and presenting at the Healthwatch conference, where we heard from such individuals who highlighted some of the issues that they were facing. So I think, we are continually learning. We're hearing from those individuals and from those population groups, those very vulnerable plus population groups that are highlighted through that Core 20 plus approach. It's a continual learning, I think, that will enable us to then tackle some of the inequalities that we see in the system.
And then just very quickly on the holistic approach, I couldn't agree more. And I think sadly the example is not unique. I think the other side to that is that patients quite often, get letters and communications that they don't understand. And, they need to try and work out where they're going, why they're going there. All the evidence points to actually, having a holistic approach to patient care is fundamentally, again, a more sustainable way of doing healthcare. And it is the direction that we're moving into. And again, our strategic commissioning plan sort of talks to that point. And you'll see within the plan, not wanting to refer to it too much, but we're also really thinking about actually how we just provide basic things like customer care really differently and much more of that, because it's not something that we often talk about in the NHS, and people are telling us we should call it a patient help desk, and we can, but actually our patients are our customers, and you know, I don't think it's wrong that we say we want to provide good customer services. And the example that you've just used, if we are able to set up those mechanisms where we're able to give patients an opportunity to question, to ring in, to say, look, I can't get through, can somebody help me, which I think is what a lot of our patients are asking, that mechanism will help us, one, to help the patient, two, again, to give us really good intelligence about the barriers and the blocks that we unintentionally sometimes put in place that patients are facing and that we should be addressing. So there's quite a lot that we're doing around that space and thinking over the next sort of 2 to 3 years as well.
If I can, just to come back to the partnership working, sort of the question sort of suggested that there wasn't much partnership working, but just to reassure members of the committee that there is a huge amount of partnership working between each of the provider organisations and the ICS on a regular basis. From a perspective of Cambridge University Hospitals, we have regular monthly meetings with colleagues over at Papworth Hospital. I meet fortnightly with the medical director from the ICS and all of the other medical directors. We have multidisciplinary team meetings. So for things that would be immediately obvious, working with CPFT, for example, on patients with eating disorders, we look after the physical and the mental health side. And you have to remember that we are currently in the process of building or about to start building a hospital, new children's hospital in Cambridge, which will be the first in its world to have a combined physical and mental health provision in the same building, which will be run by both organisations. So I think just to reassure you that there is a lot of collaboration happening all of the time across the thing, but accepting there probably could be even more if there was more time, managerial bandwidth for our clinicians and resource to share. So I think to reassure you, there is a lot going on.
We've got 5 minutes left. I know Councillor Devlin and Councillor Noel's missed questions earlier. Are there any other members who've not spoken who would like to ask a question? I also want to give Jess and Sally a chance to come in. Can you do, if you still want to choose to do it in 1 minute, please? Councillor Dr. Noel's first.
Yes, thank you. I will be very quick on this one, but I may, if I am allowed to return to my initial question, which I don't feel has been satisfactorily answered. This is what is the direction that we are moving to address the potential causal relationship in some communities in relation to social and economic status, which you've alluded to and is abundantly clear in your report, and behaviors like smoking, drinking, lack of exercise, loneliness, isolation, and so on, which I know is, again, I refer back to your paragraph 2.5, I think it was, a collaborative approach, which in brackets I think is missing one important part you did subsequently mention, which is education, should be there in big block capitals. Education about health and how to access health. The question I want to return to is that all these initiatives that you have announced that are present here and have been discussed, there are a lot of those, and there are a lot of groups that you've set up. Why not, again, I say this, why not delegate all of these, to local primary care networks, the GPs, and set up more GP surgeries? It would be less bureaucratic, it would be more effective, it would be more accessible by the population that we are targeting. Thank you.
Good point. Thank you for fitting it in. Councillor Devlin.
Thank you. So very quickly tying into that, do you feel there is a sufficient amount of GP surgeries in deprived areas or areas of growth that we see around the county? And what are your views in terms of resolving this? Thank you.
And I'll just put my own take on both of those questions. I went to the Health Watch Summit too, which is brilliant. And they had a national speaker on inequalities, and he said actually there's a limit to how much ICSs can do in this. But one thing they can do is open more doctor surgeries and pharmacies in the most deprived geographies. right? Which is essentially what the last two speakers have asked. Have you done that? And if not, why not? I am going to now take Jess and Sally before I bring the last round. Jess, did you want to say anything?
Hi, yes, and the papers are very detailed, so it's really good. So if we bring this back to the patient and what they tell us, and around health inequalities, there is some perceived what patients perceive as some discrimination coming out, but particularly in areas such as languages and things like that. So I think there's some more we could do about communicating better with the public. But I suppose from what we're hearing specifically in the last 6 months in comparison to last year, is around waiting times. And I know it's been addressed in the paper, particularly with under 18s who probably don't have as much as a voice as other age demographic. That has grown significantly. So last year, 17% of our negative feedback was around waiting times. This year, that's grown to 45%. So and I know it's been a national crisis around waiting times. And in some elements, we probably can't do anything about that immediately. So my question is how we engaging with those people about while they wait. Because a lot of the communication we're getting through is not just about complaints about waiting times, but the lack of communication during that time. So I just wanted to raise that as a point.
Thank you. And Sally?
So there's a lot in these discussions, and I think it's been really helpful, and the reports are really welcomed, and there's a whole swathe of work in there which is really positive. I think obviously health inequalities is a massively complex issue and isn't just within the realms of the NHS organisations to be tackling. As lots of people have mentioned, it's all about partnership working. So I think there's a collective responsibility for tackling some of this. And a lot of what we've talked about will touch on health inequalities, but isn't so much focused on where are the differences. So we'll talk about prevention, but actually where do we need to focus more, because there are particular groups that have avoidable issues and avoidable poorer health outcomes that we could be tackling through greater focused activity. So if you do blanket prevention, yes, it will hit those groups, but actually really you need to be delving into where there's the greater inequalities to really tackle that. So I think that's a collective responsibility. But I think all of the bits that we've talked about, so there's lots that we've talked about around the building blocks of health that will impact on those inequalities. So the employment, the education, the housing, that, you know, not everybody can tackle on their own, that we all have to be coming together on. And a lot of that is kind of within public health or council sort of areas of work as well. And then thinking about the prevention services and how we make sure that they are tackling the inequalities in the right areas. So I just was thinking when you were talking about stop smoking services, and that we've been banging the drum of stop smoking for years and years, actually smoking prevalence has gone down massively nationally and locally. But where we're still seeing high prevalence is in particular groups. So where there's more deprivation, people that have mental health issues. So where there's those inequalities, and that's where we need to be really continuing to focus. So I think it's just a reflection that there's that collective responsibility to be constantly thinking, where are the higher risk groups here? Where can we be tackling the health inequalities across all the different layers? And as we move forward with ICP, ICB working, we just need to always have that in our minds, I think.
Thank you. I'm really sorry, but it's going to be 1 minute each for the three of you to say any concluding remarks. Don't mind which order.
So if I just attempt to sort of answer the question around GP capacity very briefly. So I think the first thing to say is, yes, it is about potentially new surgeries, but it is also about how we're investing in our existing practices in more deprived areas. And hopefully you'll have seen in the report that we've done quite a lot to try and balance off any flexibility and additional payments that we are making to more take into account the deprivation in practices and make that payment, frankly, unequal to make it equal, if that makes sense. We are taking that work further now in our sort of 25, 26 and beyond settlement. So we'll be doing much more of that and making sure that our practices in more deprived areas are getting the right level of investment. We are also looking at the next 5, 10, 15 years to understand where our population is growing the most and where we would have, the biggest need for additional capacity, which maybe in part will be made by GP practices, but actually we're also considering things like community super hubs and other ways in which we can bring care closer to home or closer to our communities where that makes sense to do. I think it's also important to say that we have tried to enhance the capacity in general practice quite significantly through additional roles and responsibilities over the last sort of few years. But I think what we shouldn't underestimate, and where I think there is significant alignment between us and other public sector partners, is that integrated neighbourhood team capacity that we need to create and make weight bearing is going to be very significant as well to wrap around practices and wrap around PCNs going forward, so that we can really reach the communities that we know are underserved at the moment, because I think that's a big lever for us as well. It's not just about GP surgery capacity. So hopefully that makes sense, but we are actively exploring what is needed over the next 5, 10, 15 years, because we will see significant demand changes.
Yeah, and on the waiting times and the increased complaints around waiting times, again, I think the strategic plan highlights actually what do we need to do differently going forwards. I think the plan sets out a very ambitious approach to making sure that people are waiting well while they're on waiting lists. So making sure that people are aware of where they are and how long that will take for their appointments, for their elective surgery. But during that time, how can we look at addressing some of their wider health care needs while they're waiting? Because we all know that actually if you're in a better fit state before surgery, your recovery time after surgery is shortened as well. So there's opportunities there to get better, and that the strategic plan actually highlights all of that. Just on the collective responsibility and around, particularly around smoking, yes, absolutely, there is a huge emphasis on looking at addressing higher prevalence of smoking rates in particular. The ICB works collaboratively with the system through the Tobacco Control Alliance to identify opportunities to target smoking in higher population groups, such as the homeless population, those people who are in contact with the criminal justice system, and all of the population groups, again, through that Core 20 Plus process. We also know that Finland has a particularly high smoking prevalence. The initiatives already in place at primary care level through the PCN, through our integrated neighbourhood managers, reaching out to those communities that we know need that additional support to access smoking cessation service is already in place. So we want to build on that momentum to look at that proactive reach into those communities going forwards.
Thanks. And finally, looking at waiting times from a hospital perspective, there are two key areas. First of all, the emergency department and the strategy there that's employed here and across the country really is, first of all, to put services in place to try and avoid patients needing to come to the emergency department. So that's NHS 111, pharmacy access, general practice access. If they do come to the hospital, to try and divert them away from the main emergency department. So we and other hospitals will have a number of same-day emergency care type facilities. So for people with surgical possible problems or frailty, services, etc., to try and keep patients out of the main emergency department. And then the third thing is, if people do come along, to try and get senior decision making as soon as possible to try and speed things up. But things are often challenged within the hospital when you need to admit someone, because there's overall a shortage of beds, often because of a combination of our own internal processes, but also the fact that there are a significant number of patients in beds who are waiting for social care, etc., or further onward care elsewhere and don't need medical care in the hospital. And then the second thing is in our outpatients. And so there we try and offer advice and guidance to general practitioners and those who need it to avoid the need for a wait. So if you don't need to come to outpatients, we can just give you advice that can avoid things and speed things up. And then we're looking at the balance of new to follow-up patients so that we can start to see who those patients are on our waiting list, so that the risk for us as a hospital is the patients we haven't yet seen and we don't really know what's wrong with them, and balancing those against the patients who we do know and we know exactly what the risk is, and you just have that balance the whole time. So we're trying to increase the number of new patients that we see and reduce the number of follow-up patients, and we do that by reducing the number of extending the waiting time of or the frequency of follow-up, or seeing patients virtually, or introducing other methods such as patient-initiated follow-up. So there are a number of new and improving methods that everybody's starting to use both in Cambridge and around the system.
Thank you so much. Our CPFT friends have been very patient, so I've got half a page of conclusions here. Probably Rashenda's got pages and pages of notes. We'll get our heads together afterwards to make sure that we produce a fair record of the recommendations, but I'm not going to take time trying to read them out now with Rashenda's permission. But I will say thank you to our three speakers, and thank you so much for coming, and we wish you well in your further endeavours, and some of you will see very soon, no doubt, in other fora. Thank you very, very much. And we're not going to take a break, so as you leave the table, can I ask our CPFT friends to take your places? Jess is staying on maybe, and you're very welcome to. Okay, I'm moving straight on to this. By the way, to CPFT colleagues, you've asked to use a slide, and that is, I think, being distributed around as we speak. Item 9 is mental health services provided by CPFT. We're pleased to welcome the Trust Chief Executive, Steve Grange, who's new, and we've met virtually, but not in person. Now we're meeting in person. You're very welcome. We look forward to working with you. He's been in post since last October. Holly Sutherland, Chief Operating Officer, and Lauren Gable, Chief Financial Officer. When we first invited CPFT, it was not least in the wake of the concern that had arisen that the Trust was talking about, and we wanted to talk to them about the number of suicides. Since that time, they set up an inquiry, and then they decided to deal with the issue in a different way. I'm hoping we don't focus on whether they should have kept with their inquiry or not. I think that's been dealt with in other fora, and that we can focus on the issue of the number of suicides and are there lessons that we learn from that. But in deciding to invite our CPFT colleagues, we wanted to talk to you broadly about mental health issues, not simply focus on that issue. And I think that's the remit that we've given to you today. Steve, nice to meet you in person. Ask you to make a few introductory remarks.
Thank you very much, Chair. Councillors, good afternoon. And thank
Good
you.
word of advice to you and everyone. You have to move the machine so it's really close to your mouth, not just the angle. The machine's fine, but you have to pick it up and move it so it's with 2 or 3 inches from your mouth, and then you're okay.
I don't have to do a song and dance as well, do I, Chair? I'm just...
You get extra points if you do.
Oh, excellent. So thank you, Chair. Councillors, hello, good afternoon. Thank you very much for inviting us back to come and talk to you. I'm afraid our colleagues are different, Chair. So for the record, we have Rachel Gom, who is our Chief Nurse. We obviously have Holly Sutherland, who is our Chief Operating Officer, who is also a nurse, and joined with Dr. Catherine Maxey. I'm afraid Lauren Gable has to send apologies. We're in that period, Chair, where sickness is one of those things that I'm afraid we have to deal with. So just for the record, my colleagues are with me today to answer some of your questions. I'm very conscious that councillors also been able to review some of our narrative that we've sent for assurance, and would invite you to ask us some questions also. And I think, Chair, with your permission, so that your time's precious, we get straight into those questions. And there is something at the end of the report which I'd like to present to you, which is the slide. My apologies for tabling that, talking a little bit about the future. This is 3 months and a little bit in for myself, and it is not my first time in mental health services. I have a sort of background in mental health of over 20 years, so I'm delighted to be here to support local people. So, Chair, with your permission, if I could hand over to you, good self, to ask any questions, and then I can finish off with maybe a bit about the future.
I hear all of that, and that's great. And thank you for being willing to give maximum time for the questions and discussion. I think that's the learning experience for all of us. Safety and performance issues first, and I've got Councillors Hay, Horgan, Tevlin and Van der Ven in the first round. Councillor Hay.
Thank you, Chair. My question is, within the report under section 2.11, it says that the CPFT has seen its waiting list for assessment grow considerably during the period from December 21 to December 24, from 6,700 to in December 21 to just over 11,600 December 24. But if I go on to the next paragraph, 2.12, it goes on to say that CPFT is a below average number of patients waiting for mental health assessment and a below average number of long waiters. It feels a bit contradictory from the previous paragraph. What I'd like to know is who the CPFT performance is being compared with.
Thank you. And we do take them together, so please make a note of the questions and decide between you who you want to answer. The next one is Councillor Horgan, please.
Thank you again, Chair. I take it you do have copies of these questions in writing, do you? Because there's... Good. That's all right. And again, referring, as the previous question, to the report, paragraph 2.2, I'll read it out again. The CPFT mainly applies a by exception basis of reporting, meaning that it focuses on those KPIs, metrics which statistical process control charts indicate are subject to special cause variation and therefore potentially require improvement action, particularly if they are off target. I'm looking for some reassurance because obviously that statement makes me a wee bit nervous, and that seems a reactive approach, and I'm just very interested to understand at what point you would see moving to a more proactive approach, and what do you feel is the right balance between the two? Thank you.
Thank you. Councillor Tevlin, please.
Thank you. I have 3 points for you. The first comes from the number of deaths by suicide has been an issue at CPFT for a long time. And I say this having previously worked for the Coroner's Office almost a decade ago, and also as a governor a few years ago for CPFT as well. So I'm well aware of this. The Trust set up a Zero Suicide Alliance a few years ago, and I want to know whether this is still active and what has been achieved through this and through the Trust. I also want to ask who is responsible for overseeing the care of outpatients following their discharge, including overseeing their medication reviews. How do you make sure that support is in place for vulnerable people and who may not have people around them to advocate for them? Can you give examples of where things have gone wrong and what you have done to stop this happening again? My third point is there a clear pathway for ASD and ADHD assessment and diagnoses in Cambridgeshire, and to make sure that people are on the right pathway? Thank you.
I appreciate there was a lot there, but if you want to come back and clarify if you missed anything in that, please don't hesitate to do so. Last questioner, Councillor Van der Ven.
Thank you. My question is really to understand how the services can work in practice. Using anonymized case studies, can you give us an example of where something is working well and where a service is broken down? And apologies for the wide-ranging nature of that question.
But an interesting question. There was a lot in there. I do appreciate. I go back to you.
Thank you, Chair and colleagues. Thank you for those questions. We will answer those if I may, and then I can invite my colleagues to answer them in order. So the first question, if I can ask Holly, our Chief Operating Officer. The second question, Councillor, I'll attempt to answer that and then hand over to our Chief Nurse to support me. The third question around zero suicide, I'll ask Dr. Maxey to answer, and then my clinical colleagues to support that. The fourth area around AHD and ADHD, again, I'll invite my clinical colleagues to answer that. And then the examples in mental health are really quite tricky. And the reason, Councillor, why often we try not to give examples is because local people can identify people. And so there are areas of service that we are looking to improve, but we would be more grateful if we could suggest that rather than try to pseudo-anonymise something, because the nature of the narrative can sometimes relate back to individuals, and we need to protect anonymity and confidentiality. Council and Chair, if I can ask Holly to answer the question posed over 2.11, please.
Thanks, Steve. Am I close enough? Yes, so I think what the paper was trying to grow out to show was that CPFT is experiencing what we're seeing as a national trend in terms of rising, particularly mental health referrals. So over the past 7 years, there's been a sort of 47% national increase, and actually CPFT is experiencing the same level of increase in terms of referrals. What 2.12 demonstrates is that actually we are looking at transforming our services and how we handle those referrals, so that actually we've maintained quite a positive waiting list position. In terms of who we compare ourselves with, there isn't a national comparator. So some of you may be familiar with Model Hospital, which is a national tool that helps healthcare providers sort of compare and contrast services and outcomes and performance. That isn't up and running for mental health. So what we do is look within our integrated care system. So we compare ourselves with Beds, Luton and Milton Keynes, Herts and West Essex, Mid and South Essex, Norfolk and Waveney, and Suffolk and NEE. And actually we are below average when we compare ourselves with similar organisations along similar referrals. So I hope that explains that potential sort of contradictory statement.
Thank you, Chair. We can invite, does that answer the question? Are colleagues comfortable with that answer?
Because of time, I will give members a chance to come back if there's time, but if I could ask you to steam on with all of the answers.
Of course. Thank you very much. Okay. My next answer then, Chair and Council, is on the basis of SPC, so statistical process control, often used around data points to determine things that are statistically significant, and I'm sure you know this better than I, but Council is correct to actually say, is that assurance or is that reassurance? And so one of the things that we must do as an organisation is not rely on that data, because data itself can be misleading sometimes. It is also about the feel of our services. It's about the voice of our service users. It's about the things that we see every single day. So for your assurance, certainly my view of the way we view performance is not by exception. It's the fact that we should constantly be in a cycle of checking to see whether we're doing the right thing. With regards by exception reporting through this report, I think the concept of the narrative by exception is just to determine the things that we need to highlight to you, rather than we don't think everything is okay until it isn't, if that makes sense. And I just wanted to make that point. If I can ask Rachel just to, Rachel is our lead of quality and safety and our clinical lead, so hopefully she can support me.
Yes. Sorry, excuse me. Yes, hopefully. I think within that, what I'd add is Steve's absolutely right in terms of it's probably our language in terms of exception reporting. Within that, any performance metrics are validated at team level, service level, directorate level, and by the time we get to reporting to committees and board, they are there, therefore by exception, where we look at advising on the good things and also alerting to some of the issues that maybe need more attention and assuring on issues where previous work has been completed and all actions have been taken.
Thank you very much. And so the other thing I just advise council is also going out there and walking the wards, going and talking to our staff, going and opening doors and opening cupboards is also incredibly important. We never take anything for granted and never should. So if I can move to the next question, which is on zero suicide and an overview of ADHD. So if I can ask Dr. Maxi, our Deputy Medical Director, to try and answer this one, please.
Hi, thanks, Steve. Just for introduction purposes, I'm Dr. Catherine Maxey. I'm Deputy Medical Director at CPFT. I'm also a consultant psychiatrist. I work in a community mental health team in Peterborough. For the point around zero suicide and our suicide prevention strategies within CPFT, just to clarify, Cambridge and Peterborough is not an outlier in terms of the number of suicides that the region has. We are absolutely committed to suicide prevention, and we also have within CPFT a number of ongoing areas where we promote that prevention through our patient safety implementation framework and also through our newly invigorated Learning from Deaths committee and process around learning from deaths through that. Your question specifically, I think, asked around the previous group, which was a zero suicide group that operated within CPFT. That group doesn't operate anymore. We are part of the system-wide suicide prevention steering group, which follows and implements the system-wide suicide prevention strategy. I think that has superseded the need for an in-house zero suicide group, if that makes sense. We didn't have a system-wide suicide prevention strategy at the time when we had that CPFT standalone group. So we work together with the system and continue with our in-house programme of quality improvement for suicides. I think could you repeat your second question? Would that be okay? Around outpatient care and examples of where it's gone wrong.
Yes, so the question is, who is responsible for overseeing the care of patients following their discharge, including overseeing their medication reviews? How do you make sure that support is in place for vulnerable people who may not have people to advocate for them? Although you said the point about examples, sort of any examples of best practice or where you might have had any issues around this, and what have you done to prevent any issues happening around this? Actually, yeah, the last point doesn't necessarily matter, but so basically, how do you make sure that the support is in place for vulnerable people who may not be able to advocate for themselves following being sort of released back into the community?
Thank you. So I think it's quite a broad question, and there will be some service-specific answers, because depending on whether we're talking about a patient who's with us for mental health reasons or for physical health reasons, the answers might differ somewhat in terms of the process of who's responsible for their care following discharge. But there are very clear governance procedures in place for all of our services. We do work with a particularly vulnerable patient group, I absolutely agree, and we have a specialist clinical expertise in assessing mental capacity and working with social care colleagues to make sure that we are looking after those vulnerabilities. So that involves multi-agency working and includes offering advocacy and protection for those people who are either under the Mental Health Act or under the Mental Capacity Act. And I just wanted to add, in terms of what do we do if something goes wrong? We have a reporting system within CPFT that where everything is collated. And to give an example of how we learn from when things perhaps don't go as well as we would like them to clinically, we have some trust-wide learning forums where we share the learning from incidents or from clinical scenarios where things could have been done better, which is a lessons in practice forum which operates trust-wide.
Thank you, Catherine. So the last question, Councillor, was we touched on, if you don't mind, the anonymisation of something. But if Council will just indulge me, for the first couple of months, starting my role with the Trust, I've tried to spend as much time as possible with our service users, their families and carers, talking about what they feel our services offer rather than what we think we do. I've been able to reach out and speak physically to nearly 1,000 of our workforce, which isn't enough yet because I'd like to see the rest. But one of the things that I've been able to identify is some areas where we are really getting it right and some areas where we need to improve. The areas where we need to improve, I think it is very safe to say that the services that we provide, we're privileged to provide services to those that sometimes need quite complex care and sometimes most definitely need multi-agency support and multi-agency care. And when things don't go as well as they could, it's often when we don't collectively connect as system partners between ourselves, whether it be local authority, our ICB colleagues, acute colleagues, and our processes can get in the way. Every time I've seen that happen over individual cases or individual issues, I have been really pleased to see that those processes have been moved to one side, the family member, the patient, or the service user has been put central to that. On my first week in the organisation, I bumped into a family that were walking across our site that appeared to be upset. And as I was walking around orientating myself, I asked them if they were okay. I think they were a little bit surprised that some random man walked up to them and asked them if they were okay. But I explained I work there, and I asked them, did they need a room to sit, because they looked very distressed. And they didn't need a room to sit, but they asked me what I did for a living, and I told them I was the new chief executive. And they were really forthcoming in the fact that they'd received really bad news from some of our clinicians about a loved one. But the way in which that had been done, the engagement with the individual who was towards the end of their life, and the care that was given to their family, the reason why they were distressed was because of the loss and potential bereavement associated with their loved one. The thing that came out really strong was the culture of care that was offered and the compassion that it was given in. That was on my first week, Chair. That gave me a huge amount of hope in terms of what CPFT should be about, what every NHS provider should be about. But I go back to when we aren't really as effective as we need to be. Often it's because procedures and processes get in the way. And the one thing I would like to say is a plug to our integrated care system. The ICB in this part of the world is incredibly effective at joining partners together, and I thank them a lot because they are passionate about mental health, they're passionate about children's services, learning disability services, and our community services. And one of your new colleagues in the corner I've spoken to already is also passionate about our population health. And I think there's a significant amount of opportunity here to fix some of those interagency issues that we bump up against each other when things get difficult. But we always collectively put the person in the centre. So I would invite some of you in the questions. Some of you have asked to do a site visit or a tour of some of our facilities and to come and visit our wards or our departments or our functions. Please do. We would love that, actually. And let us unashamedly show off what we're proud of. And let us equally allow you to talk to some of the people who we care for to get a first sense assurance. And I'm not being crass here, Council, when I say that's not an SPC chart. That's about an interaction with a patient or a family member that makes more difference to me every day of the week. Chair, if I may, I can hold here if you want to ask questions, or I can lead into the slide, dependent on your time frame.
Yeah, do you mind holding, because I've got another round of members. We'll take all of the remaining ones that have given prior notice. Councillor Taylor is first.
Thank you, Chair. So I'm going to touch on workforce and collaboration. I know you've spoke slightly on collaboration with different services. As we know, there is a 24-hour telephone support line for mental health crisis, which is absolutely much needed. However, there's always a however, isn't there? So sorry. Ambulances are often called to support a resident in a mental health crisis. They're not always presenting emergency physical conditions. Ambulance clinicians are not trained for mental health. The patient is then taken to A&E, which can see them waiting for long periods without help. So, I've been doing a bit of research. Norfolk and Waveney have been piloting since 2001 a mental health response vehicle, which are crewed by East, ambulance clinicians, and a mental health nurse. A second car has been added, and data shows now that 4,671 patients have had contact in this way. 90% of them were able to avoid being admitted to hospital through further support within our community. So have you considered this approach? Do you talk to your peers? So you're looking at Norfolk and Suffolk Foundation, because I think this is something that within our area we really need to look at. Thank you.
Thank you very much. Next, Councillor Daunton, please.
Thank you. Maybe I should make it clear that I am the county-appointed governor on CPFT, so welcome CPFT colleagues. I've got two questions. One is that there's a new leadership team at CPFT, and so how could you explain now how you're balancing running two major hospitals alongside a wide range of community services across multiple sites? It's an unusual model. So that's my first question. My second question is rather bigger, and it may be that it's being dealt with by the slide at the end. What's the longer term strategy in relation to staffing, culture and finance? Longer term strategy.
A couple from me. On the suicides point raised by Councillor Tevlin, as I say, I don't want to focus this discussion to be should you have kept your inquiry or not. I think it's a cul-de-sac, right? But what can you learn from the record on suicides, I think, is a very apposite question. I'm a bit worried, I hope I'm wrong, but I'm a bit worried when I hear, well, we're not an outlier to anyone else. That sounds a bit like we haven't got a problem. There clearly is a problem. You've had two coroners tell you that you've badly failed your policies. You've had the local media saying that there's a culture of cover-up. You've had your former chief executive who stood down on the record saying that you had got things badly wrong, unquote. I haven't heard that this afternoon. I haven't heard that you've recognised the scale of the problem that you had and that you're dealing with it. And I'm a bit disappointed by that, I have to say. And I hope perhaps you can reflect on your answers and be slightly more candid in answering them. The second thing is this, and I don't apologise to Steve for putting a question in public to him that I put in private, but I think a lot of the discussion in the paper, the slide and the rest of it, policies, processes, practices, fine, in a very technical way that you need to do to run your trust. I do not criticise you for that at all. You're doing your jobs and you want to make it even better managed, and I wish you good luck with that. However, from the public's point of view, and this is a public event, and members of the public, including your patients, are watching, I think there's not a sufficient reflection, either from us as questioners or from you, about the scale of mental health crisis there is in Britain. And I say Britain because this is not a Cambridgeshire problem, it's a national problem. But when you look at the Cambridgeshire Quality of Life Survey and the horrendous levels of mental health concerns there are in our community, especially amongst young people, but not restricted to that, I think all of us, but of course, first and foremost, you're in the front line, stand accused of just failing to meet the scale of the crisis. And I know resources are part of that. I know that there are systemic issues that you're not in control of, and I don't hide either of those things. But I do think the public deserves to hear from you whether you recognise the scale of mental health crisis there is in our society, in our communities, and how you're best coping with that given the constraints that you face.
Thank you, Chair. Are we closed on that round of questions? Yeah, thank you. So the first question around the crisis response and the cars, if I can ask our Chief Operating Officer, Holly, to answer that, please.
Thank you, Steve, and thank you for the question. So yes, we are constantly looking for areas of best practice. So we have been working with our colleagues at the East of England Ambulance Service. We did have a mental health joint response vehicle. Unfortunately, our colleagues at the ambulance service weren't able to continually provide the staffing. So actually that has paused, but conversations are still ongoing around how we could restart that. We're also looking at, because we do have a joint response vehicle with the police, with police colleagues, and actually seeing if we could do something sort of, you know, as a try in terms of police, ambulance and ourselves, and looking at how we could strengthen that community response. We've also linked in with our voluntary sector colleagues. So there is a sanctuary where patients can go to if they don't require sort of physical health support and therefore don't need to go to an emergency department. We're really well aware that for the majority of patients in a mental health crisis, the emergency department is not the right place for them. The other thing that we've done is strengthen our advice and guidance. So actually our ambulance service colleagues can phone through to our first response team or our crisis team to understand whether the individual that they're with is known to us and potentially get some support in terms of understanding how to manage that individual. But we do recognise that that joint working and having that mental health joint response vehicle up and running would be really beneficial for our patients and our community. So that is something that we're working with. The other thing that we're doing is, as part of a sort of winter project, our ICB set up an urgent and emergency care hub. So trying to provide a single point of access. Actually, this winter that focused on physical health, but we're already in conversations around how do we expand that to recognise that actually mental health is just as important, and actually there are just as many people requiring that mental health support as there are physical health.
Thank you, Holly. Thank you very much. The next question, Chair, was around the new leadership team and also, Councillor, thank you for asking that, and obviously also thank you for being one of our governors, because you're able to shape certainly our current and future with insights that are incredibly valuable. Yes, we're a complex organisation. One of the things that is often most complex about organisations like ourselves is we're dealing with, and Chair's point is incredibly important, some of our most vulnerable people in society, some of the most complex, difficult challenges that they face, and that is connected to other agencies such as our social care setting, our education setting, housing, and so on. So in terms of recognising Chair's question over the longer term mental health issues of Great Britain, I think the short answer to that is every single day, Chair, because that's why we're here. But secondly, without being flippant, we can't do this in isolation. It has to be something that is much wider. And so the juggle of managing the day-to-day delivery of effective, high-quality care, stretching out into how do we understand the future, how do we map the future, and how do we work collectively to get a better future, is something that the leadership team is committed to do. 3 months into the organisation, one of the tasks I have, as you would expect, that the board has set me is to determine a very clear 5-year strategy for the organisation. I don't want that strategy to be something that's on a shelf And I most definitely don't want that strategy to be written in isolation of our partners or our people with lived experience or our public. So we've started a new direction around the organisation, establishing the leadership commitments that we'll make, the care quality commitments that we will make, and also the approach that we will be taking to listening to and responding to the experience of those people that we care for. With regards to the longer term strategy around those three areas of culture, workforce and finance, the financial issues that we face both as an NHS and as a provider within it are challenging. I'm sure you're aware of that. However, that's our duty to try and make those ends meet. And in many cases, that is not on our own, and we do that in partnership with other agencies. And I would like to say at this point a very significant thank you to the voluntary sector and charity sector agencies that work in our communities that support people with long and enduring mental health issues that we cannot do without them. And so as we work collectively through our strategy, I will be making a commitment that we will reinforce and strengthen those relationships as best we can, and we will make them meaningful. In terms of the culture of our organisation, I can't comment, Chair, on the previous administration or some of the issues of the narrative that you've seen, but I am committed to making sure that the organisation's culture is transparent. It learns from and listens to those with real lived experience and living experience, and is something that we can believe passionately about what we're trying to do for the betterment of our population. And then finally, our financial position as we move forward. Our month 8 position wasn't great. However, our month 9 position, our public board is meeting next week. Our month 9 position is positive, and we are starting to move towards a break-even position at the end of the year, which is something that we've had to try and do. However, I would say this on record, Chair, that we must be very conscious that every time we try and make efficiency, that is not the prime narrative of why we're here. The prime narrative of why we're here is to look after people, and therefore the money must come second. It is part of our job, it's part of my job, and I accept that fully. However, we must never do anything that dilutes the quality of the services that we offer. So we are forecast for a break-even position, working with our ICB and our other partners to deliver that on behalf of the system. And next year, although it will be challenging, we will go through exactly the same process to do that collectively together. With regards Council's question around suicide, if I can ask Dr. Maxey to comment on that, and particularly, Chair, I'll come back to the national forecast around population health statistics, and obviously we have working relationships with directors of public health, thank you, and also our own directors of public health to try and understand what the future looks like, because just carrying on as we are is not good enough to support what the needs are in the future. So, Catherine, can I hand over to you with regards to the learning from suicide, please?
Thanks, Steve. And yes, absolutely happy to reflect on the previous statement. Suicide is a tragic and preventable consequence of severe mental illness, and we're absolutely committed to preventing suicide within CPFT. I know I can speak for all of our clinicians who work within CPFT that is core to what we do. So I really want to emphasise that we really are committed, and I hear what you're saying around the coroner's criticism that we received previously. We need to do the right thing for our patients and for the carers of those patients, and particularly for the families of those patients who have died through suicide. I will hand over to Rachel in a minute, if that's okay, because Rachel actually met with some of those families after the coroner's inquests and may want to talk to some of those meetings that were held in broad terms. I talked that we are part of a system-wide suicide prevention strategy, but we're also very committed to our own internal programme for reducing suicides for those people who are under our care. There are numerous things that go on within CPFT to address suicide. It's not just one thing. It's our care in its entirety. It's what we do. So there are programmes within CPFT that are working very hard to make sure that we provide the care that we need to prevent suicides from happening. That can be things including things such as access to ligature points on wards as part of our inpatient transformation programme, right down to relational work with service users and with their families, personalised care planning. All those things are going on. And it also comes down to the treatments that we provide and continuing to advocate, coming back to Steve's point, continuing to advocate for the treatments that are patients with severe mental illness need in order to get well and reduce and prevent suicides. The processes that are in place now are very different to the processes and systems that were in place 5 years ago. We did not have the patient safety implementation framework 5 years ago, which is a very different systematic way of learning from incidents and deaths. We did not have the learning from deaths processes and committee and learning processes that we now have within CPFT. So there is a landscape change from previously. If I can come to Rachel, maybe if you wanted to add around some of those personal meetings.
Yes, certainly. Thank you, Catherine. As Catherine said, following the thematic suicide review, the changes within that, at the time we were in contact with many of those all the families, and offered to meet with them. Many of them did request that, and we, myself, our Chief Medical Officer, Dr. Cathy Walsh, and the Interim Chief Executive Officer at the time, Scott Haldane, we met with many of those families. And what was absolutely apparent within that, how valuable it was for us, number one, to hear their stories, and obviously very challenging and sad for everybody, but how valuable that was in hearing them and being able to explain the changes within the trust, and as Catherine's just talked about, but also many of those families have now are now party to the learning, the quality improvement measures that we're taking. But what was absolutely apparent was that the process for the thematic suicide review, those families, if they had been engaged in that, their personal needs weren't going to be met by a thematic process. And I have to say also how appreciative many of them were at the end to say that they'd had the opportunity to speak directly to us, but also that was acknowledged, and we are still in contact with them. Thank you.
Thank you. So, Chair, your points that you made just before you handed the microphone back to myself, I think, Chair, I would never want our organisation to disappoint you or anybody that we look after. We are fully cognizant of the difficulties we face every day, and we are fully cognizant of the fact that since COVID-19, there has been a significant statistical increase in some of the issues that we deal with, and our public health colleagues and population health colleagues can help determine some of those in a more detailed way. This is why we need to work collectively together to understand what that looks like. There are services that are fit for purpose now, but we need to move into a space that is more accessible, more meaningful for those service users. There is a different approach that we may need to take around some of the issues we've talked about here, but we also need to work with our partners in other sectors, including primary care, as well as our voluntary sector colleagues, as well as our acute colleagues, and indeed social care and health. I think the issue for us as we move forward, and Council asked the question over the juggle again, or the balance, we have to be really unrelenting in getting the fundamentals of care right every single day. And that's a duty that we have as individuals, that's a duty that we have as organisations. And I want to lead an organisation where 4,500 of our staff, or thereabouts, because it changes just on a daily basis, but around 4,500 of our staff universally believe that, and I believe they do. I think the next bit, though, is understanding how research can help us, working with our university partners in a different space, looking to utilise some of the new innovations in care, looking to utilise AI, looking to utilise different models of care, and learning from other partners, other sectors, other countries, and indeed each other. That is really important, because it's only that will get us through to support the Secretary of State's vision for health. And as you know, probably better than I, Secretary of State talks about 3 major delivery points for the new NHS plan, which is to move away from hospital to community. And I think this trust would like to also move from community to home. I think we talk about moving from analog to digital, and we want to also embrace AI in a safe space to help us be more productive, to stop wasting some of our potential energies on things that perhaps don't add value. And then the third is a most definite move away from treatment or diagnoses and disease to prevention. And in that narrative, Chair, we must never forget that prevention also includes mental health. And that is something that's incredibly important for us. That will all be part of our new strategy. And if I could be cheeky, Chair, I think I'm likely to ask you good selves as an OSC and as an authority to help us build that strategy so that you can own that too.
I don't regard that as cheeky. I regard that as partnership. I'm trying to make the most of the time. I've got Councillor Tevlin and Councillor Nawaz who want to come back, and I see Councillor Slatter who's not spoken. So I'm going to ask you to do it, perhaps Councillor Slatter in 2 minutes and the other colleagues in 1 minute each. I'm also in your last answer is the opportunity to talk to your slide as well. There'll be one more answer. So Councillor Slatter first.
Thank you. I think of all the 5 NHS trusts you deal with, you are the one that's the universal and probably should be the nearest to our hearts. And I hope that we have a role to play with you. And I wanted to introduce something that's never been mentioned to my knowledge in this committee at all, and that's membership of an NHS trust. They're a weird animal. If any of you are involved as governors, you'll know. Well, Edna's looking at me, she knows the problems I've had. Because it just, it's not the sort of thing we would invent ourselves, put it that way. However, I think in terms of your trust, and I'm looking at your website and how you actually make an offer to people, because you need to have a few members to be governance, to get it right. Do you offer things? And you offer, for example, members' health talks, and I know others do that, seminars and mental health awareness training courses. Now that rang a bell with me because I think the mental first aid courses you can get, I've been lucky, I've been a member of St John, I've done this at Winter Company, you get the training courses on the back of doing stuff, and then you know stuff that can be helpful. I've never done a first aid mental health one, I keep meaning to. Now, if that's the sort of thing that you flag up, the more people you've got out there who can see the warning signs, maybe find out, especially if they know somebody who's had 2 years of really doing well and getting off their medication, and then they seem to have a bad day, that you can help them in one way, whereas somebody who's never had a problem before, it's out of the blue, you help them in another way. I'm just guessing, I've not been on the course yet. So may I suggest, and if we can help with it, and it comes under public health, I don't know, Sally well enough to say no, if she can we have some money, please? But if it comes through that sort of way, and it's part of what we can do for everybody, may I ask if we can help in that way? And Chair, this can be a nice lead in on us, what we can do.
Thank you very much. 1 minute each. Councillor Tevlin first.
Thank you. I'm sorry, I didn't get an answer on is there a clear pathway for ASD and ADHD assessment and diagnoses in Cambridgeshire to make sure they are on the correct pathway? And then my other point ties in with the suicide prevention and what has been discussed. Looking at the strategy, may I suggest looking at specific at-risk groups like young people? I know there's been a highlight within CPFT around young person suicide and those with eating disorders. So it would be good to understand what work has been done so far on that as well, just to round up what has already been said. Thank you.
Thank you, Councillor Dr. Nawaz.
Thank you. Yeah, suicide actually has hit an all-time high, and it's not being talked about enough. We need to talk more about it. My question, actually, substantive question, is about the epidemiology of mental health. What is the prevalence in the urban and rural areas of mental health? Obviously, the latter has greater isolation and loneliness, and therefore more smoking, drinking, etc. One group that you haven't mentioned are the children and young people. The mental health issues in children have been increasingly recognized, and the suicide rates amongst the young men in particular. I know you said that money is secondary, doesn't matter, but looking at your own report, to be euphemistic, is quite a challenge. Surely it will impact on your strategies to tackle mental health issues. And would those strategies be different for rural and urban areas and young people, or would it be one standard approach? Thank you.
Thank you. I think if you did justice to those questions, it'd take about 15 minutes. So I fully accept that in a short time you'll do your best to answer them, but it's impossible given the time to be able to give them probably full justice.
Thank you, Chair. If I may, I'm going to ask Holly to answer the pathway associated with attention deficit disorder, ADHD and AHD, and then I'll try and wrap up the questions that we've got and perhaps help by follow-up if we need to talk about some of the detail, particularly the epidemiological aspects, because there is a lot of work in that space, Council, which is incredibly tailored, but we need to probably come back with that rather than, but I can answer it very briefly. So Holly, can I ask you on the AHD, please?
Thank you, Steve. And in the interest of time, I will be brief, but very happy to have a longer conversation around it. In short, yes, we have pathways both for children with neurodevelopmental conditions and for adults with ADHD and ASD. I think it's fair to say that actually those two areas are where we've seen our biggest increase in terms of referrals, and actually they are our most challenged waiting lists. So both within children's and adults, they are absolutely our most challenged waiting lists. So there are two separate pieces of work being done in conjunction with system partners and the ICB. So for children, we're looking at actually combining sort of autism and ADHD to bring it together to being a needs-led neurodevelopmental pathway. So rather than focusing on diagnosis, actually really understanding what young people need, what help will practically support them to live their best life. In terms of adults, we are looking at all sorts of options, which sometimes include actually looking at other providers. So actually really understanding who are the patients that need to be seen by CPFT, but actually who are those patients that might be able to be seen by other organisations, and working with the ICB to make sure that actually our commissioning arrangements enable that flexibility. We've also, we're really utilising the primary care mental health service, which CPFT also provide. So actually we've really strengthened that triage process so that patients are going to the right service first time. So again, trying to reduce some of that anxiety around those patients not potentially being on the right waiting list, but also helping them in terms of waiting well and giving them sort of advice, signposting them, linking them in with things, because we know that they're waiting a long time.
Thanks, Holly. And if I may, just on the back of that, Councillor, if there is any particular area of interest or any service that you'd like to visit, please let me know, because again, the team would be delighted to host you and walk through that in a bit more detail so you can actually see it, which would be very, very powerful. Chair, I'm going to try and answer the questions. So if I may, sorry, Councillor, not to correct you, but I hope on record it doesn't say that I've said that money doesn't matter. I'm sure the Treasury might have a different opinion. It does matter. It shouldn't get in the way. And I think at this point, it will always matter because it's the best use of the public purse to deliver what we're there for. With regards to the epidemiology, look at, Sally, for a second, excuse me, the co-determinants of health, the socioeconomics, the education acuity, the housing deficit. So all of those things make a very rich and a horribly complex environment for us to live in. And when we start to add rurality, urbanization, we look at age specifics, we look at all of those aspects of the use of technology, social media, et cetera, it becomes rather complex, which means that one collective size does not fit all. And therefore, what we have to do is we have to understand our communities. We have to listen to them in terms of where our best interventions are. And we also have to check whether or not they're effective. And the only way that we can do that is to check their development, excuse me, through a co-production lens, check their efficacy in terms of the outputs, which are our KPIs, the SPC stuff, but also check how it feels and whether it works by talking to our communities. All of that richness, including our diversity, our gender alignment services, our protected characteristics, means that we need to make sure we tune into those populations and we give them a service that they can resonate with. The short answer to that is we'll continue to work with our social colleagues, social care colleagues, and population health colleagues, public health. And there is a developing strategy around health inequity that Dr. Faulkner is pulling together from CPFT to plug into and support the work that the ICB mentioned prior when I just joined. And so that might be something that Council would like to be brought forward to talk about where some of those interventions are being tailored. And rural mental health and urban mental health are very challenging because they're very different. And whether that be different upbringings, different environments, access to different routes or support, and all of those complexities, that means that we have to understand those areas before we can start working in them. Finally, Chair, I don't think I've ever in an OSC been called weird before, so I'm going to take that as a significant compliment. Thank you, Councillor. But then Councillor offered me money, so I'm very happy on the back of that. So if there is an opportunity, yes, please, is the short answer. Getting the message out that the stigma around mental health needs to be removed. You know, 1 in 4 of us, 1 in 2 of us, 1 in 1 of us will encounter some form of mental health issue, or know somebody. So it is the same now. There is no health without mental health. People can see a broken leg or a sprained arm. They can't see an invisible illness. So we need to make sure that we collectively, particularly from a local authority and citizenship model and a health model, work together. So any offer of help, yes, please. And if you'd like the training, please be my guest. And then tell me whether it's any good at the end. And Chair, thank you. That's a deal struck. Excellent. We'll show you around and I'll make you a cup of coffee, Councillor. The 8 areas, Chair, I'm going to be very brief now because of time.
It's literally 1 minute. We've got it, so we can take it back and read it. So just 1 minute, please.
Yeah, no problem. 8 areas of focus for the Trust, Chair, over the next sort of 6 to 12 months. The first and most important is quality and safety. We've touched on that. The second, which you've touched on prior, which is people, culture, and our organisational development, how it feels to work for us, how it feels to be cared for us. The third area there is our research and innovation, strengthening our partnerships with our 2 major universities, but also our business schools locally for employment, and that stigma aspect of getting into those areas, working with our voluntary sector through good communication and good partnership. A digital transformation agenda is massive and we need to embrace that, but we need to do that safely. Strategic planning is talking about the future, learning from each other and working into that space. And then probably one of the most important things that's passionate to my heart, Chair, is the co-production of lived and living experience and engaging those who use our services to help shape our services. That includes carers, families, partners, yourselves, and every one of us. That's really important for me. And then solid good governance, which is the area that I'm focusing the organisation on over the next couple of months. And we can come back with our strategy, Chair, when there's a bit more bones, a bit more flesh on the bones.
Thank you to all of you who've appeared this afternoon. Again, I'm not going to attempt a comprehensive stubbing up, but reinstating the joint response vehicle, putting extra focus on ADHD pathways and waiting lists would definitely be in there. I think the assurances that you've given us about developing future orientation and strategy, but doing so against the scale of the crisis, I think was a strong finding. And on the suicides issue, I think the second round was much more candid, so I thank you for that. And I think you've been willing to talk about where things are different and better now, in your view. But I did think the earlier answer, I can't comment on what the past administration did, it doesn't wash. I think, you know, we're all accountable public bodies and all of the knowledge is there within your trust. And until and unless you can be comfortable about talking about what were the shortcomings, I think there is still going to be concern in terms of public confidence and events like this. And I would ask you to reflect on that in terms of how this afternoon has gone. I do think, though, that your final message about stigma and tackling stigma and the responsibility that we all have is a very strong message and one that we should all own. And I thank you for that, as well as all of your continuing work. To the members, on the work programme, when we do our next prep meeting for the following health scrutiny in March, we'll put some time in to discuss the work programme so that we get some future ideas then. So when you come to that session, can you please be ready to make your suggestions? So that indeed ends our business for today. Thank you all to all the members and all the officers and all our guests for taking part, and I declare the meeting closed.